All right, guys. Today we're going to be talking about respiratory emergencies. My name is Adam. I am a paramedic, so I have a little bit of experience with respiratory emergencies. We just got this little PowerPoint here we'll go through, and it kind of takes us through some different stuff. It's pretty basic, pretty vague. We're not diving in too deep into anything. So first off, what are respiratory emergencies? Are there different types, and do we treat them all the same? Anything? What is a respiratory emergency?
I'll say anything that makes breathing difficult.
Okay. Are there different types of respiratory emergencies? Yeah? What's some different types?
What's that, COPD or something like that?
Uh-huh.
That's the one where you get like fluid in your lungs, right?
So, that would be more of like mucus. That's a lot of like obstructive like mucus and stuff like that. Fluid in your lungs is another. That would be congestive heart failure. PCOPD, CHF is what they call it. It's kind of confusing with the different ones. And do we treat them all the same? No. Okay. So the upper respiratory tract, we're then going to divide it in between upper and lower. The upper respiratory tract contains your nose, your mouth, your tongue, your jaw, the oral cavity, your larynx, and your pharynx. So basically, from your vocal cords up is what we consider your upper airway. And there's actually a lot in there. The main functions of your upper airway is to warm, humidify, and filter all the air in what you breathe. It begins at the front of your nostrils and it ends right there at the vocal cords, kind of like I just said. So some common upper airway emergencies are obstruction. This is a very common one, and the most common airway or obstruction would be your tongue, especially for unconscious patients and stuff like that. But this is still a very common one, even if it's not the tongue. Common things are, you see your generalized choking symbol. They could have difficulty talking, breathing. You could hear some stridor, and you can also see them start turning blue or cyanotic. And they can eventually lose consciousness. Hopefully we fix it before then. So some ways to manage and treat the obstruction would be do your abdominal thrust, but it's also, if the patient's still moving air, and they're still maybe able to talk a little bit, or you can see that they're kind of moving some air and they're not quite blue and stuff, the best thing to do is just encourage them to cough, like see if we can cough it up and get it out. If it's a complete obstruction, they're not moving any air, that's when we definitely want to jump in and start doing abdominal thrust. I know that AHA this year had talked about alternating between abdominal thrust and back blows. So you would jump into doing that, especially if there were signs of a complete obstruction. If that didn't work and the patient went unconscious, you just want to lay them down. That's when you start CPR, and you just keep every time you go to breathe for that patient, just look at the airway and get a good look to see if you can see the object and potentially get it out with some medial forceps. And if you're unable to do that and you're not having any luck with a BVM, or if you're not able to intubate, that's when we would go in and do like a surgical crike, and just hopefully we can crike on the other side of that object, so we can ventilate the patient. Another common one would be croup. Croup is very common in pediatric patients, ranges 6 months to 6 years, and it's really common in your winter months. I don't know if you guys ever heard croup before. It kind of sounds like like when they're trying to breathe, they call it the seal-like bark. If you know that and you ever hear it, you will immediately know that's croup. It's very, it's a one-of-a-kind kind of sound. But other than that seal-like bark, they can have some stridor and just hoarseness in their voice. And it's normally due to a viral infection somewhere in the body. And it's typically not fatal, but it is very common in the pediatric patients, and it does require some treatment sometimes. It can get pretty severe. You can manage it with nebulizing albuterol or epinephrine. You can, I don't know if you guys know this, you can nebulize epi, like for electric reactions, you can nebulize that, just like you would albuterol. And then you can also administer solumedrol, which is a steroid. It helps with smooth muscle relaxation. And then if they worsen, then we could start like a magnesium sulfate drip and give them that, which also kind of helps smooth muscle relaxation.
You talk about nebulizing epi, can't they, don't they have little epi shooters now like they do Narcan too?
Yeah, they do. So they're doing that now, especially for, instead of handing out the EpiPens, they're doing those just because they're a lot more cost effective. A lot of, it's not new science, but a lot more people are jumping onto like intranasal versus intramuscular or anything like that. Because a lot of our medications that we use, they can be absorbed through your nose. And especially with kids, like now you go from having an allergic reaction and then now you're stabbing them in the leg with a needle. It's kind of a traumatic thing versus just kind of squirting a little bit of stuff in their nose.
I was gonna ask if they're having trouble breathing and you give epi intranasally, do they breathe it in or is it absorbed up into your?
So a lot of times the device that you use, it'll like make it a mist to where it's not like straight liquid. You can do straight liquid, it'll eventually do its thing, but a lot of those devices they'll have, it's kind of like doing like a nasal spray for allergies or something like that. It'll kind of mist it out. Depending on the dose, it can, you might see it run out a little bit, but hopefully most of it got up in there. But yeah, I know we have them, it's like a styrofoam thing, we call it the MAD device, and you just screw it on the syringe and it'll make it a mist for you. Kind of fine it and fan it. So that's kind of, with the croup, this is kind of what you're seeing. So it's basically your vocal cords get really inflamed in your larynx there. That's why you're having difficulty breathing, because these are your vocal cords, that's your trachea, so that's where your oxygen needs to go. And if it's inflamed and it's constricted, then that's going to constrict how much oxygen and air is actually getting into your lungs and coming out. Epiglottitis is another common airway, upper airway emergency. Your epiglottis is the flap that covers your trachea when you swallow, whether it's food, water, anything like that. It can become inflamed, which can be kind of sucky because that's a big flap there. So that can definitely reduce the amount of area that the oxygen has to go in and out. It does progress fast, and it can lead to a complete airway obstruction. The common cause of epiglottitis is flu B, and it's commonly seen in unvaccinated adults. These patients will have like a lot of drooling, and then you can also see fever, sore throat, hoarseness, and then hyperextension of the neck where they're just trying to, that's just your body naturally trying to relieve a little bit of that to allow some air to go in and out. So this is like a real life picture, that's why I included it. I thought it was pretty cool. So yeah, that's a pretty big obstruction. Most of your upper airway emergencies are swelling, which causes obstruction. So when you're treating this, you want to avoid laying them down because that'll cause that to kind of lay back and cover your trachea. And you really don't want to move them a whole lot or go in, especially with a laryngoscope, and try to visualize the airway, because you can make that more angry, which will make it swell more, which gives you less time to actually do anything about it. With these patients, you want to administer oxygen fast. Honestly, with any respiratory emergency, you want to go ahead and put them on oxygen fast. And then you can administer EpiIM, which will help hopefully reduce some of that swelling. And you can also nebulize the epi and then give solumedrol. Advanced airways should be prepped and ready to go. I would include 2 different ET tube sizes and a cric kit. I would use the ET tube that I thought was appropriate, and then I would get a size below that. When you're doing these airways and you go to intubate this patient, you need to have everything set up and ready to go, because you might only get one chance to do this. If you get 2, you better be quick. If your intubation attempt fails and they are becoming completely obstructed, it's nice to have the cric kit there ready to go, because you're not going to get around that. You're just going to have to cric if it becomes fully obstructed. So I know we kind of just hit on it a little bit. Anaphylaxis is another very common upper airway emergency. This is due to inflammation and angioedema. So angioedema is just your tongue swelling. This can be, so anaphylaxis is technically in 2 or more body systems. So if you have your hives and then difficulty breathing, that's anaphylaxis. But sometimes people take medications or something and it might just upset their belly a little bit. That would just be classified as allergic reaction. And you can have allergic reaction that can have some facial swelling and stuff, but most of the time, anaphylaxis is going to be where you actually see the difficulty breathing part of this. And it can be caused by common things like food, medication, and a simple bee sting. Common signs and symptoms would be your facial swelling, your hives, and then that stridor when they're trying to breathe. The treatments for this would be your IM epi or IN, if you see that on the streets. I haven't seen any of those yet. I'm kind of curious to see how fast they'll get those out. Benadryl and albuterol, famotidine, and solumedrol. So you got your bronchodilator and your smooth muscle relaxers, and then that antibiotic there. So with kids, this is kind of tricky because, like I said, they're freaking out because they just had a scary airway thing, and then you jab them in the leg. So a lot of times the pediatrics I've showed up for anaphylaxis, they were more worried about why they just got jabbed in the leg than they were why they couldn't breathe. So now we're going into the lower respiratory tract. Your lower respiratory anatomy is your trachea, your bronchial tree, your alveoli, and then the lungs themselves.
Can you say those again?
Your lower airway is your trachea, bronchial tree, alveoli, and your lungs. The main functions of your lower respiratory tract is to bring air down to your lungs and do that gas exchange between oxygen and carbon dioxide. And that occurs at the alveoli level. So a common lower respiratory emergency would be asthma. Asthma is the reactivity of the trachea and bronchia, and it's a variety of stimuli. It's just a hyperactivity that results in a widespread narrowing of the airways. This can make them short of breath, and when the airways narrow, that traps that oxygen in there, so it makes it difficult, if any, gas exchange to happen. This happens in the distal portions of your lungs, and it happens in those alveoli where that gas exchange happens. These patients will present with shortness of breath, wheezing, and a lot of times your classic like tripod positioning. Severe cases can have cyanosis, which is your blue color, altered mental status, and they can be unresponsive. Treatment for asthma will be albuterol, nebulized in. You can do ipratropium and solumedrol. And then if they continue to worsen, that's when we can do magnesium. But these patients also, when you get there, sticking oxygen on them pretty early is always really beneficial. And then if you don't have albuterol, ipratropium, or any of these medications on the truck, if it's an asthmatic patient, they probably have them in their own inhalers. Depending on how many times they've already taken it, you can kind of assist or tell the parents to do it again. And a lot of times, depending on how severe their attack is, getting them to exhale all the way, and then as they're inhaling, squirt the albuterol in, that helps get that medication down in their lungs, because the bronchodilation is what that does, so it don't do anything unless it actually reaches their lungs. So just timing that spray really helps. So another common lower respiratory emergency would be your COPD, emphysema, and chronic bronchitis. COPD causes air trapping due to excessive amount of mucus and damage to the bronchi and alveoli. A lot of this is due to like smoking. Honestly, this is the common cause of this would be smoking. Signs and symptoms are excessive coughing, wheezing, bronchi, and shortness of breath. So bronchi is kind of one of those lung sounds that's a little weird. It can sound very similar to rales, which is what you would see, or crackles, is another word for it. That's what you would see more in like a CHF patient. But bronchi is just that mucus, junky, nasty sound. And COPD is also caused by lung irritants. If I know a lot of guys that have worked in factories for a really long time, they'll end up with COPD just from all that stuff they breathed in for years and years. And your COPDers, they can be barrel chested. Just looking at them, like skinny guys with big barrel chests, that's a sign of that. We can treat COPD with albuterol, ipratropium, solumedrol, and last step would be MAG again. Those 4 drugs there, that's going to be your most common airway emergency drugs to use. Some interventions to stop COPD before it even gets to this point would be change your lifestyle, stop smoking, make sure you're vaccinated, because sickness, if someone gets the flu or COVID or anything like that with COPD, that's when they go into COPD exacerbation. Pneumonia is a big one too, that will cause them to just go off the rails. And sometimes a lot of COPDers are the ones you see walking around with the O2 tanks with the nasal cane. So congestive heart failure / pulmonary edema. CHF, congestive heart failure, is a weak heart that does not effectively pump the blood through the body, which causes blood and fluid to back up into the lungs, causing pulmonary edema. So I know this is fake, but that's basically what it does. Your heart can't effectively pump blood through the system, so it just backs up into the place of least resistance would be your lungs. When pulmonary edema is present, the alveoli is full of fluid, which makes it unable to exchange oxygen. Signs and symptoms of this would be a productive cough. Some of these coughs can contain pink frothy sputum. It is gross when you see that, because it's just really thick. I mean, it's, as it says, thick frothy sputum. And it can be pink, red. I've seen it like almost like an orangey tint. These patients are going to be short of breath, and their lung sounds will be those rails and crackles. It honestly sounds like you've got your stethoscope up to like a pool or something. You can hear the air going in, and it's just bubbling it like a hot tub. So common treatments with this would be your CPAP. Depending on their blood pressure, we can do nitroglycerin and furosemide. CPAP is great because it forces that fluid down and hopefully out. The nitroglycerin opens up your blood vessels. It opens up your blood vessels to give that fluid a place to go. And then furosemide, that's a diuretic, so it helps relieve your body of any fluid. If you give a patient furosemide, they're probably gonna pee themselves. That's a common thing, these patients pee a lot. Any questions? Like a lot.
What's the difference, like, so where do you actually use CPAP? Cause I thought you used CPAP for, what was it, COPD? Or
So-
maybe I misunderstood.
No, so CPAP can be used with honestly any respiratory emergency. CPAP is honestly my go-to, like my first line go-to when it comes to your congestive heart failure when they're full of fluid. But you can also use it for asthmatic patients of COPD because that really forces that air. Because CPAP stands for continuous positive expiratory pressure.
Mhm.
So it's a continuous positive pressure ventilation system. So it forces that air down into your lungs. It works well with your pulmonary edema because it forces that fluid down and out. But like a COPD patient or an asthmatic patient that's like has those more shallower breaths, kind of like I was talking about before with the albuterol, it really doesn't work unless it's getting into your lungs.
Mhm.
You can do an inline nebulizer with the CPAP, which would take that medication and actually force it lower into their lungs.
But you said it's your go-to, does that mean you use it on pretty much anyone with a respiratory emergency, or?
This is my go-to when it comes to pulmonary edema / congestive heart failure. When it comes to like asthmatic patients and COPD, it's not the wrong thing to do, but I personally find myself trying to, and it really just depends on the severity of what's going on at that point. If it's just kind of mild or even slightly moderate, I normally throw them on like a non-rebreather with an inline nebulizer first, just to see if they can kind of help themselves. Your COPD patients, you can knock out their respiratory drive if you force too much air on them. So even though you're doing the right thing by giving them oxygen and treating it, that can also be taking away their body's natural response and respiratory drive. That's pretty common to be seen.
As a basic, technically, the only thing we're allowed to give is what, albuterol, right?
Yeah.
Cause you had those 4 other main medicines, I don't see the nitro and stuff on there.
Yeah.
Nitro you can give, they have it prescribed to them as a little tablet.
Yeah, so this would be kind of one of,
ALS stuff.
this is definitely more ALS, like that would be more ALS in this scenario.
But I mean, you also, as a basic, could be assisting.
Yeah, so absolutely, so basic can assist, like, honestly, the hardest part of all this is getting that CPAP on. When you're putting CPAP on a patient, it feels, I don't know, have you ever put one on? So it's scary, especially if you're short of breath and now you're forcing air in, and it's not forcing the air in is not the problem, but this makes it feel as if the patient can't exhale. So every time they take a breath, it's easy because the air is going in, but when they try to exhale, there's pressure against that. So a lot of times when you're doing the CPAP, the best thing to do is try to slowly introduce the mask. Like you have to walk them through it, let them breathe in it, and just kind of get used to it. And I always just kind of hold it on my hand, and if they're slowly freaking out, I can pop that seal just enough to kind of let them, take a good exhale breath. But when it comes to pulmonary edema, the faster you can get an actual seal and not break it, the better off you are. Especially, this is PEEP. It's controlled by PEEP. So positive expiratory pressure. So PEEP is just, it allows air to stay in your lungs after your breath. So it doesn't let them close all the way, because every time your lung closes all the way, then it takes more air to open it back up. So it just keeps that lung open and just keeps pressure in there. And so every time you pop that seal, you lose that, and you basically have to start over. So the faster you can get it on, the longer you leave it on is best. These patients do very well. Unfortunately, out in the field, I don't know of any system, EMS wise, 911 wise, maybe some critical care trucks, but EMS systems that actually have BiPAP. BiPAP is great because it does the same thing CPAP does, but it lets them exhale. So it's constant pressure during the inhale, which is where it counts, and it lets them exhale. So if you can just talk the patient through this to get them to the hospital, and once you make that transition, because I hardly see any patients actually stay on CPAP at the hospital. So if you can get them talked through it, where you can get to the hospital and do that change onto BiPAP. It's difficult, but that's about the best case scenario. Some more questions? I know we kind of blew through it. It went kind of fast.
Not sure.
I was going to say something else. Oh, I know what it was. So when you're talking about COPD and CHF, think about it like a water bottle. So a lot of times COPD, it doesn't really change. Oh yeah, I'm glad you did that. So I'm glad it doesn't really change. So a lot of COPDers, they can lay down and nothing changes. They can breathe better when they're sitting up, but it's not a drastic thing. If you have a patient that's short of breath, you go out to them, and like I said, rails and rock can sound very similar sometimes. So an easy way to tell, I wouldn't lay any of these patients down just to try this, but if they're laying down when you get there and you're unsure, if you sit that patient up and all of a sudden you get a pretty good drastic change in their breathing status, that's a good sign that you're looking at a congestive heart failure patient, just because you're making all the fluid go down to the bottom of the lungs. Another sign and symptom of congestive heart failure would be like swelling and edema in their feet and hands. That stuff can get pretty gnarly too. Sure you don't have any more questions? Well, I gave you guys the test and then also an evaluation sheet. Speak your mind, don't hold back. I know I breezed through it pretty quick, but that's it. If you guys don't have any more questions, then that's it.